Good evening, everybody here. And today is the week number 16 in Anesthesia and Critical Care Refresher course. And good evening, everybody here. And today is the week number 16 in Anesthesia and Critical Care Refresher course. And as usual, we have two lectures tonight. The first one will be about hemodynamic monitoring by Dr. Ahmed Fouad Madi. And the second lecture will be with Dr. Amr Salam and awake craniotomy, the anesthetic approach, and more. So let's start straight away with the first lecture with Dr. Ahmed Fouad Madi. So Dr. Ahmed Fouad Madi had got his medical degree in 1993 and his master's in 1998 and his MD from Tanta University Hospital in 2008, more than 12 years ago. He had the fellowship of critical care medicine in 2012, and he is currently an assistant professor on two universities. First one in Egypt is Tanta University Hospital, and the second one is in Saudi Arabia in Riyadh, Muhammad bin Saud Islamic University in Saudi Arabia. And he is as well a fellow of the critical care medicine in the American College of Chest Physicians. He is the program director of critical care fellowship and residence program in the MOH in Riyadh. So he is an eminent speaker, and Dr. Ahmed has a lot of research interests. I saw him doing his first, or one of his very first researches in H1N1 in 2011, and in the MERS-CoV after that, and after he's interested now in the COVID-19, hemodynamic monitoring, a lot of researches as well in different critical care hot topics. So I watched and listened to Prof. Ahmed Madi multiple times teaching in different hemodynamic monitoring tools and new equipments. So it's my pleasure to invite him tonight again and speak of one of his points and areas of expertise. And Dr. Ahmed, please start sharing your screen and go ahead. We are all ears here. Thanks so much.
Okay. Thank you, everyone. Thank you, Dr. Walid, so much for this very nice presentation. Actually, me and Walid are friends since long time back, and very generous presentation is always giving me more than what I deserve. Assalamu alaikum, everyone, and I hope you have a very good night, academic night today with the refresher course, a very distinguishable event, and I'd like to start with the hemodynamic monitoring in ICU. It is a huge topic. When Walid asked me to present overview of hemodynamics, usually it would take almost days to present overview of hemodynamics or hemodynamics. So I tried as much as I can to touch every part of hemodynamics. And the main concept of these presentations to open your mind and storm your brain how to think about the patients when you need to deal with hemodynamics in circulatory failure patients. First of all, I don't have any conflict of interest, but I can disclose that I retrieve many slides from the figures of the hemodynamics worldwide, like Prof. Tipoul, Ziver Mouni, De Becker, Ken Inchi, and Jean-Louis Vincent. So I retrieve some of their slides actually to show you in this slide. I'd like to also announce I have many flowcharts I try to read by myself, as well as quoted from others. I hope it will be beneficial for everyone as a collective hemodynamic parameters. As of all, you know that hemodynamics, one from the very important cornerstone of the monitoring in the ICU. And usually you need hemodynamics when the patient will be in shock, either to help you to diagnose the type of shock, as well as management tool to help you how to deal with the patient at the therapeutic range. And the most important, to predict it early as a preventive measurement, not to wait until the patient will be in failure to have the to use your tools of hemodynamics to diagnose your patient. For example, if you take this a very common case, all of us have it in our ICU. You can find a patient which is old age coming to your ICU, which is known to be bedbound and admitted in shock state. The first impression in ER, they diagnose her as UTI. She's done the M and the hypertension, ischemic heart disease. She received 2 liters of crystalloids. Her MAB was 55, heart rate is 120, urine output is low, capillary refill time is prolonged. Of course, when you look by IVC, I'm always consulting Walid. This is an area of interest, as well as our Prof. Ashraf Tayyar. They have the empty IVC as well as the poor cardiac function. If you look to this slide, you can find many hemodynamic parameters. Just look at the blood pressure, heart rate, urine output, IVC, contractility. All of these are items or parameters of hemodynamics. How you can integrate all of this to diagnose this case? This case may be somewhat clear, but if you look deep in this case, you can find she's bedbound. She can be as obstructive shock. It can have PE. She's also ischemic heart disease. She can be cardiogenic also at the same time. And UTI is the first impression. So it can be any type of shock. So you have different scope for shocks in these patients, and you have different parameters. How you integrate all to help you, how you manage this patient from hemodynamic point of view. I just remember a long time back when I'm studying, when I'm teaching my students about the shock stage, I'm telling them when you think about shock, just think about the garden, right? Of course, if you want to supply your garden with water, what do you need? You need a water pump, you need a hose and a release valve, as well as you need the water itself. The same like shock. Those are the types of shock. When you feel your patient have a pump failure, so his problem will be in the heart. If you have the problem with the vessels, either due to obstruction or vasodilatation, so you have a vasculature problem, either distributive or you have obstructive shock. Of course, if you have losing for intravascular volume, so you are dealing with the patient with the hypovolemic shock. So we will retrieve from this a perfusion of triangle. Perfusion triangle, which is the heart, blood, and vasculature. It's very essential to help you to diagnose this case as well as to treat here. So think about this garden when you're dealing with the patient in shock. Of course, the complicated case have mixed type of shock. Another very, very important message I want to tell you. When you look to this perfusion triangle, you can divide the shock stage into different phases, different categories. If you will start to treat this patient with the fluid, let us see here. When you try to treat the fluid, what's your target? All of you said, I want to keep MAP 65. I want to improve his cardiac contractility. I want to improve his oxygen carrying capacity. I want to improve his oxygen delivery and the oxygen saturation. All of this considering your target when you start to treat. But don't forget to look at the last station. to look at the end user, which is your cell. You have to monitor the downstream, because the main definition of shock is cellular hypofusions. So keep in your mind the target at the end to be your cells. And we have interface, we have intermediary phase between both of them. So if you are looking to the upstream, which is macrocirculation, and you are targeting to monitor the cell function at the end, you still have in between the microcirculation. The microcirculation, another category, another phase. So I'd like, actually, when you think about hemodynamics, to think about those three phases, those three stages: the macrocirculation as well as the microcirculation, and keep in your mind to follow up and monitor the cell's function itself. When you have this diagram in your mind, you will know, first how to deal with the shock patient. All of us looking to the macrocirculation, which is, we are assuming we have a patient with cardiac output. The cardiac output, the four determinants of the cardiac output, all of us will be happy if the heart ejects a good amount of the blood, which is stroke volume. But we need to think how this can be done. It can be done through improving the four determinants of the cardiac output, which is the preload and cardiac contractility, as well as heart rate, and of course the resistance in front of the heart, which is afterload. So even though I'm recommending don't keep those as objective, those are tools, and the monitoring those parameters are tools in your hand to help you to achieve your target, which is the cell function at the end. So if you are looking to the circulation, you can find this is the, keep in your mind this circulation, systematic circulation. Of course, I will not go in details because pulmonary circulation has also influence on the hemodynamics, very essential, but the main circulation we have is the systemic circulation. Looking to the preload in the venous side, looking to the heart as the contractility, and of course in the arterial side, which is the afterload. Again, your target is cells. And in between the macrocirculation and cells, as we have mentioned earlier, is the microcirculation, which is the very, very important. If you are looking to the history of hemodynamics, long history, long time back, when they thought that the flow is bumping by the heart, so they start to feel the pulse. When they start to feel the pulse, to know how much of the amount of the fluid of the blood moving inside the arteries. After that came the sphygmomanometer and the blood pressure. Then it came to us the Fick principle, which is the first robust cardiac output monitoring through a principle which is created by him, which is saying the blood flow to the any organs is equal to the amount of, let us say, indicator take by this organ divided by the arterial oxygen content of that indicator. This indicator can be a dye, like Hamilton said, and the first one, which is Werner, did use the dye indicator indocyanine green to estimate the cardiac output in 1956, and he awarded a Nobel Prize in the physiology and medicine during the time because he's measuring cardiac output. After that, 1970, of course, came the idea of the pulmonary artery catheter and the balloon floating to reach the pulmonary artery, and he can now differentiate between the right and left side, and he can estimate the cardiac output. From 1970, many devices coming to the market, many. I can say Bico, Nico, Vigilio, Ledico, EV1000, many of them, even microcirculation, cytochrams, oxygen saturations, all of them came to tell us we have tools which can help you to determine the patient. All of this, mostly, they are pointing at the macrocirculation. If I did ask you a question, please reply in the chat box. What is the most important and the first hemodynamic tool? When you have a patient in shock or whatever, what is the first hemodynamic tool? I hope to receive some answers in the chat. Just tell me the first and the most important hemodynamic tool. I cannot see the chat here. Let me try to find it. Yes. Heart rate, blood pressure, urine output. non-invasive blood pressure, capillary refill, very good. MAP. Okay, that's enough, please. I'm agree with you, but with very little percentage. Know why? Nowadays, I'm watching the series of the physician. Those, you and me, are the first and the very important tool of hemodynamics. You can imagine if you have really, yes, the physician is the first hemodynamic tool. You can imagine if you have this screen in your monitor with multiple of parameters, blood pressure, pulmonary artery pressure, wedging pressure, cardiac index, whatever you said, many parameters. And you don't have the personnel which can interpret these parameters. It's useless. So you, as a physician, is the first and the important tool. Don't forget your clinical sense. Don't forget your physical exam. Don't forget your interpretation of the parameters. This is the most important point and the first message I'd like to convey to you tonight. You is the most important hemodynamic tool. Of course, if you go to the basics, you can find many of them. But like heart rate, as you have mentioned, like blood pressure, like every basic hemodynamic point, all of them are essential. But unfortunately, all of them didn't have the sensitivity and the specificity which can tell you where is the problem exactly. Even the blood pressure, you can find the patient whose blood pressure is normal, but is still complaining of low flow. If we take the blood pressure as a hemodynamic tool, as some of you mentioned in the answer, blood pressure is not only the systolic. Systolic can give you a reflection of the stroke volume. Again, when you think about any parameters, try to think about the main concept we have mentioned earlier, which is contractility. So stroke volume can give you clue about the stroke contractility, how much stroke volume. What about the afterload? Yes, MAP can tell you what is the resistance in front of you in the heart. And the diastolic can give you, the diastolic blood pressure can give you reflection about the systemic vascular resistance. And the MAP, which is a very important parameter for the blood pressure, can give you a hint about the perfusion to the organs. All of us know the target MAP for everywhere for septic shock patient, which is enough to have patient with 65 in circulatory shock patient. But consider, even this number of 65 is not absolute. You still have the patient who needs higher. You still have patient which can tolerate lower with the same perfusion, with good perfusion to the cells. So dealing with the number, don't make it a fixed number. You have to deal with adequate parameter figures. You are not dealing with absolute number of whatever you have. So MAP, one from the very essential tool in hemodynamics, but why you are selecting MAP rather than the diastole and systole? If you look to this MAP is the driving force to the organs. It is the perfusion to the organ. For that, all of them, they said MAP is very essential for the hemodynamics. Again, MAP doesn't affect the distance from the heart. Whenever you are measuring the blood pressure from anywhere, from the aorta until the saphenous artery, MAP, it is almost the same. MAP reflects the true blood pressure inside the whole vasculature, and it doesn't affect by underdamping or overdamping. So MAP is essential for that. So how we can calculate the MAP? If we go back to the physics again, Ohm's law tells us MAP, it is the multiplying of the flow and the resistance. Of course, here the flow is the cardiac output. So cardiac output, which is stroke volume multiplied by the heart rate, multiplied by stroke by systemic vascular resistance. So when you think about why your MAP is low, you have to think about these parameters. Again, stroke volume, which can give you clue about how much the contractility of the heart, of course, will be affected also by the preload and afterload. So when you have a patient with low MAP, think about heart rate too high, too low can causing low MAP, as well as vasodilation, which is affecting SVR. So when you think about MAP, think about what factors can giving you low MAP for such a patient. Is it afterload, or is it the contractility of the heart, or it is the preload, or we have heart rate affection of the MAP? So don't take it absolute again. Think about the meaning behind the parameter you will have. If we go through the cardiac output and MAP, some flowchart to give you clue. For example, if you have the patient with low MAP and high cardiac output, so almost this patient have vasodilatation like septic shock patient, or you are using vasodilators. If you have low MAP with high cardiac output, with low cardiac output, so almost the problem would be in the preload or in the heart failure. But can you have a patient with high MAP with dropping cardiac output? Yes, if you are using excessive vasoconstriction like vasopressors or pain, or if you can have a patient with high MAP or high cardiac output like the patient with fistula, like using extra entropes or extra fluid resuscitations, you can have those patients with high cardiac output with high MAP. So coupling the ventricular function with the MAP, you can reach to your diagnosis. This is the first parameter, which is basic parameter. The second basic parameters, which is all of us know about it, which is the central venous pressure. Central venous pressure is a huge dilemma. They have a very common survey published and distributed in the worldwide. They're asking the anesthetist, which is the most important parameters guide you for the fluid management for your patient, either pre-operative in ICU. Most of them, 75% of them replying central venous pressure. And the dilemma of central venous pressure worldwide until now. Is it useful? Is it harmful? Shall we use it? Shall we not use it? Many updated literature talking about this, and I do recommend to repeat out. I collected most of them, and I can disclose. This is, for example, 33 statements for the basic hemodynamic monitoring published by all figures worldwide about the hemodynamic. They said CVB should not be used to predict or guide fluid resuscitations. So, shall we remove it? Shall we discard the CVB now? Still, my opinion, not no. You have to use it. There is a space for central venous pressure to can use. If you think again about the same circulation, CVB affected by the cardiac function, which can give you back pressure, as well as the venous return. Venous return have two important factors: main systemic pressure in the periphery of the veins and the upward pressure, which is central venous pressure. So central venous pressure, it is the upward force, upward pressure of the venous return. So when you think about central venous pressure, you have to think about venous return as well as the cardiac function. Yes, it can give you clue about the preload, how much inside the systemic circulation, venous circulation, but it will never give you clue about this patient will respond to the fluid or not. So keep in your mind, when you have CVB going higher and still cardiac output, significant rise in cardiac output, so it means your patient have almost right ventricular dysfunction, and this patient candidate of echo. So I think it is very essential to know the limitation of central venous line. Still, you need it for the perfusion of any organs. If you look to the perfusion pressure for any organs, still the CVB is present. So you have to use it to know how much the fluid inside the preload, but don't use it as a marker for the fluid response. And you have to know the limitation of CVB rather than to discard it completely from the ICU. This is the basic parameters in hemodynamics. Don't forget technicality points, how to connect it, how to make zeroing, how to make leveling. So again, if you never mind, this is a small, very, very hint about the technical leveling and zeroing of the lines, whatever you are, central venous line or pressure. This patient, for example, 40 years old, they connected him with the A line in the radial artery. They make good zeroing for this patient. And after that, blood pressure at that time was okay. After that, his wrist fall down, arterial catheter in the radial artery, and fall down from the bed 20 centimeters below the heart after zeroing and after leveling. How well blood pressure displayed on the monitor compared to the patient's actual blood pressure? You understood the scenario? A line in the radial artery, zeroing done, leveling done, reading very well, then the rest fall down. So the pressure on the monitor, it will be 20 millimeter mercury higher or 15 higher or equal to the actual pressure or 20 millimeter lower. Let us see how it's doing on. A, C, C. Okay. Of course, sorry, I didn't do polls. Huh? But I can see all of you answered all the answers. We have A and we have B and we have C. Let me tell you the message from this one. Actually, the right answer is C. Whenever the catheter it doesn't affect your reading. What affects your reading is the leveling, the transducer level. You see also even the technicality, the nurse rule and the zeroing and the leveling is very essential to have a good and the correct number. So if transducer on the same level, so almost you have actual number. This is the same. But if you take the transducer above, right? So we'll have now false lower reading than the actual. If you're taking the transducer lower, so you have false higher than the actual. So this is just a hint or refresher to keep you in mind about the technicality of even using the parameter, not only the beneficial, the interpretation of the parameters, also the technical has an important point. Oh, again, let us see, we have certain figures. Always nowadays in the medicine, they said, don't rely on the static figure. Static figures, whatever it is, even in the infection. If you did ask, how much leukocytic count today? It is 12. What does it mean for you? It's 12. Yes, it means something if yesterday was 8, was 7. So the titr, the dynamic change of the figure, is very essential and it is more robust than the static figure. Dynamic parameters in hemodynamics, it is a part of the intervention and measurement. You have the parameter to measure, you have intervention to be done, and then you will measure the same parameter again. And you will check how is the effect of the intervention of the parameter you have measured. They are relying on the mechanical ventilation to increase the venous return to the heart, and they are checking the stroke volume or the pulse pressure to tell you how is the effect of the preload increasing or augmenting the preload or the challenging of the preload on the cardiac output. This is the dynamic indices. We have many of the dynamic indices as well as the static measurements. CVP, pulmonary arterial occlusion pressure, global end-diastolic volume, flow time corrected by different devices. So many devices giving you the static measurements. Of course, dynamic would be better. As we have mentioned earlier, whatever the dynamic you have, whatever the tool or the test you have, dynamic means you have monitoring parameter, intervention done, and then you are monitoring the same parameter again. The most common, all of us knows, we are relying for fluid responsiveness. We are augmenting the preload. We are changing the preload with the mechanical ventilation cycling change during inspiration and expiration, and you are expecting the preload will increase on the Frank Starling curve. So we have positive fluid response. So this patient almost will respond to the fluids. Whatever you are measuring, stroke volume or pulse pressure, whatever you are measuring in the parameters or in the monitoring tool, right? Keep in your mind, we don't have fixed graph for each patient. Even in the same disease with different stages of the shock, this graph can change. It is totally dynamic. So this patient can have septic cardiomyopathy. The heart cannot respond for the preload. At this stage, it will not be responsive. Right? So when you think about dynamic and the fluid responsiveness, you have to think about the status of the heart. Does it respond to the preload or not? As well as the stage of the shock itself, which is very essential because it is related to the timing of the response to the fluid. Again, what intervention here? Mechanical ventilation changes. What the response here? It is the stroke volume. You can take on that many of the parameter or many tests to be used for the fluid responsiveness. Of course, hundreds of literatures, they are comparing the static versus dynamic. Of course, dynamic always won. Pulse pressure variation, stroke volume variation as regarding sensitivity and specificity. The same concept like the interesting, the very, I cannot say new, I can say now point of care, the point of care monitoring parameter for the patient with ultrasound and echo using the same concept. Intervention and response, whatever on the level of the inferior vena cava, superior vena cava, or aortic, or LV outflow tract by echo. So the same principle. Again, I will not go to each one in details, but I just want you to remind you with the limitations. Before you will know the beneficial of any test, you have to know what is the limitation of that test. You can see it here. We have, it is well known, well-established predictor for volume responsiveness, but we have many limitations you have to consider when you are dealing. The patient have high intra-abdominal pressure, the patient have so much arrhythmia, the patient having right heart failure. All of this were reflected on your the fluid responsiveness test. So what you will do during this stage, you will just change the intervention from mechanical ventilation to another intervention to be done, doesn't affect it by the cyclic change of the pressure, which can be occlusion of the expiration or passive leg raising test or many fluid challenges, and the parameters you are measuring would be the same: pulse pressure, stroke volume, aortic VTI, or the diameter of the IVC or SVC. So fluid responsiveness, again, is a tool to help you to predict, does this heart will respond to the fluid you are giving or not, which is very essential. Many, I can say more than 300 literatures coming to the market to assess the sensitivity and the specificity of the fluid responsiveness. And of course, it is well known to be used for the shock stage patients. Okay, so what about the heart itself? What about the stroke volume? How you can measure the stroke volume and cardiac output? If you look to the technologies, many technologies, and I'm not here to give you like a shopping mall or a shopping market to marketing devices. No, I'm just giving you the concept. We have many concepts or many technology behind the estimation of the cardiac output, like thermodilution. The first one used by the Swan-Ganz. After that, it came transpulmonary indicator dilution and arterial pressure waveform interpretation. It can give you clue about the cardiac output. Esophageal Doppler, echo, carbon dioxide rebreathing, depending on the fake principles, or bioimpedance and the bioelectrons, which is the least sensitive, least invasive maneuver to measure the cardiac output. So much technology is coming. The first one and the gold standard with the highly invasive one, which is the pulmonary artery catheter. Of course, it is not now the time to discuss it in details, but I just want to tell you, even when you are interpreting the data by pulmonary artery catheter, you have to think about the main concept. What parameters can give you clue about the preload, which is stroke volume, can measure CVP, occlusion pressure. The other parameter can give you hint about contractility, cardiac output, cardiac index, stroke volume of the left and right side, and also afterload. So when you think about the device, please think and interpret systematically about this device. What parameters give you clue about the preload, contractility, as well as afterload? Of course, all of us know the debating about we have to use or we don't use the pulmonary artery catheter. It is long debate since long time. Many meta-analysis done to tell us pulmonary artery catheter, it is neither increased overall mortality or days in hospital nor conferred benefits. But in well-trained hand, still it have a space. And believe me, all the new devices we heard about, all the devices, comparing the accuracy and validation by the pulmonary artery catheter, this is what was the gold standard. Then they are kicking it out. So it is a gold standard. It has many complications. The most common complication of the Swan-Ganz is interpretations, misinterpretation of the parameters, right? But still it has space for the patient to have ARDS and complicated cardiac function and cardiac dysfunction with the ARDS. Another very nice and non-invasive tools, most of anesthesia they are using in the pre-operative stage, which is esophageal Doppler. Just a probe, you can pass it inside the close to the descending aorta, measuring the descending aortic blood flow, and give you a graphs and numbers. Very simple technique, esophageal Doppler, to measure the stroke volume. Again, even with this device, think about what the parameters can give you hint about the preload, flow time corrected, how it looks like if you have preload reduction or this patient needs flows to increase the preload. What about what the parameter giving you afterload? Yes, stroke distance, how far it will bump the blood, how far the distance from the stroke volume from the in the descending aorta, and it means this patient needs afterload reduction. Microcontractility, peak velocity, how high of the wave, the peak velocity, also contractility. So again, think systematically. When you have a device, think, interpret the parameters systematically. The another techniques, which is almost all of us know, transpulmonary thermodilutions. The most two common techniques in all devices you have on the market, either pulse contour analysis, which is using analysis of the pulse pressure, or time integral for the dye, whatever the dye. Can be the temperature, can be the option, can be the carbon dioxide, which is transpulmonary thermodilution using the cold saline to measure the stroke volume through two lines one in the central venous catheter and another one with the thermistor in the arterial side outside the thoracic cage. So we call it transpulmonary. Many parameters you have to get through them. The most two common devices measuring the using the transpulmonary thermodilution is EV1000, which is the more recent one, and the PICO, which is the almost old one, and both have the same parameters, right? So transpulmonary thermodilution, these devices are comparable to the gold standard, which is the pulmonary thermodilution, which is the pulmonary article. So we will have the screen of both of them. Oh my God, it's complicated. Yes, but again, think about systematically. What the parameter in this screen give you clue about the preload? Just take a look. If you look here, we have global endostolic index, which is the amount of the blood in the fourth chamber at the end of the diastole, as well as CVB. The same, two monitor, we have the same global endostolic volume as well as the CVB. Plus, of course, the responsiveness we have here, stroke volume variation or pulse pressure variations. So this is the preload as well as the responsiveness. If you think about the parameter who can give you clue about the contractility, yes, we have global ejection fraction, stroke volume index, or we have cardiac function index or cardiac index on the other device, whatever is it. If you think about the afterload, we have SVR and MAP. Look at here. So interpret the parameters of the monitor, which is almost complicated monitor. So when you think about systematically, you can reach to the diagnosis as well as the intervention you need to do. Very essential parameter here to be added for the transpulmonary thermodilution, which is the safety. When you have to stop, when you have to take your fluids out, this is the very essential. Look at here, the parameter giving you this clue, which is extravascular lung water as well as pulmonary vascular permeability index. In both parameters, we have it here in purple. You can see it here, this one and this one. So those are the safety and studied very well in the literature, as well as some monitoring giving you continuous measurement of the central venous oxygen saturation. Like here, you can find it continuously, assessing the balance between delivery and the utilization. The importance of the safety parameter, let me focus on this one. As all of us know, your lung is dry, dark, and dank space to allow gas exchange easily. Extravascular lung water, any fluids outside the pulmonary vasculature. You can imagine it is very less amount. 200 ml of extravascular lung water, the patient will be drowning. In the literature, very good marker for the mortality. You can be doubling of the extravascular lung water, you can find mortality reaching to 50%, significantly high. So very high risk and sensitive marker you have to keep in your mind when you're dealing with the shock patient, especially shock ARDS or cardiogenic, both of them, because it will answer the question when to stop fluids and when to remove it from the body. Another flow chart, I like to have it here. It is published 2018. If you can see it here, this is just to compare. If you have the patient with normal lung, so almost he has low vascular permeability as well as low extravascular lung water. If the vascular permeability increasing, as you can see it here, ARDS at risk without increasing the extravascular lung water, right? If only extravascular lung water increased and pulmonary permeability index is low, so almost your patient have left ventricular failure and hydrostatic pulmonary edema, cardiogenic pulmonary edema. So vascular permeability give you clue about which type of shock you have. It is cardiogenic or it is non-cardiogenic. Simply through this one. Okay, so we have many devices now on the market. So what can I will use? Which device and for which patient? This slide or this title, it is another lecture alone. But just I will give you a hint. Simply, you have many parameters to assess which device to use for which patient, based on the technology, based on the invasiveness, based on the which is more accurate. But simply, Allah ymasih bil khair, Dr. Gamal Hashimi, I think Dr. Riti knows him well. He was working in his center in Jeddah. Now he's in Canada, right? He published in 2015 a very nice integrating of the cardiac output based on the setting. He mentioned if you are in the ward, you just need the less invasive techniques. like bioimpedance, like Doppler, like non-invasive. If you are in emergency department, maybe you need uncalibrated, or we can say self-calibrated, like Vigilio or like Ledico. If you are in OR, maybe you require, if you have ETT, you can use bioimpedance, you can use NICO, you can use applied fake principle, Transesophageal Doppler, or uncalibrated technique. But in ICU, the patient is always hyperdynamic. The shock is not, it's not stationary phase. So you need more advanced technique, which is almost the either pulmonary artery catheter or calibrated, which is either EV1000 or PICO. So simply where you are using the device, right? Okay, so one from the important flow chart. Let us put everything together from the macrocirculations. What you have to do, and what we are doing in our center or everywhere, in our ICU and everywhere. If you have the patient in shock, first assess his cardiac function to exclude cardiac element. If his normal cardiac functions, just look to his lung. If we have lung injury, if no lung injury, only cardiac output, only shock stage, shock, so we need only basic monitoring. Basic monitoring, which is mean central line and arterial catheter. But if you have the patient with lung injury or limitation of the fluid responsiveness, or if your patient have abnormal cardiac function, so those patients need advanced techniques, either pulmonary catheter or they need the Transpulmonarythermodilution techniques. So simply assess your patient, right? If he's only cardiac function, circulatory shock, so needs simple techniques. If it's combined circulatory with cardiac and ARDS and limitation for the test you have, you need those patients to go over more advanced techniques. Let me another question I will ask you. I found in my ICU and everywhere, you can have many patients in ICUs with this screen. Blood pressure for this patient, he's a septic shock patient, but blood pressure 100/60, and the heart rate saturation accepted. But you can find your patient have this picture, or he have delayed refilling of his capillary. Are you happy to have the patient with target map 65 and still have these signs? Of course, no. Right? We did agree for that. Why? So you need to think, you need to retune your targets. MAP is not a target, it is just a tool to reach to the microcirculations. Those patients have lost the coherence between macrocirculation and the microcirculations. Keep in your mind to treat this incoherence between macrocirculation and the microcirculations. Again, I will remind you with this picture, with this slide, you have 3 stages. You can have shock in the macrocirculation, but the patient is okay in micro and in the cell perfusions. And the most important, you can have normal macrocirculation in this stage, but still you have problem with the microcirculation and downstream in the cells, hyperperfusion. So you need to think about those. You need to think about the parameters who can give you clue about the micro as well as the cell function. Simply, perfusion markers can be done through, as we have mentioned earlier, the clinical examination. Skin temperature can give you clue. Does the skin warm, cold? Capillary refill, one from the, let us say, primary assessment for the patient in shock stage. If, of course, it's prolonged more than 5 seconds, to be associated with poor prognosis. Skin mottling, one from the very common score in sepsis, you can find it with the severity. With the high score, more patient will die. Less survival, as you can see in these studies. It is well studied, well done. And you can see it here in the knee or in the elbow. Whenever you have mottling higher, more patient will die. Of course, this is just a clinical examination and assessment. You need to have a biomarkers. You need to have indicators. Now, the most common indicators you can find is lactate, mixed venous oxygen saturation or central venous oxygen saturation, as well as carbon dioxide gap. All of us knows lactate is the hallmark of shock. Believe me, first thing you need to ask about it when you have a patient in shock, how much is lactate? Is it cleared or not? It is very well studied since long time back. It is not new, right? Even in the absence of physiological derangement. Even, I have a case, real case, all his microcirculation it is normal, but his lactate is was always 4.5. Even she's conscious, she's doing very well. I have real cases like this. We discovered with time she has ischemic bowel, she has peritonitis, she's developed septic shock later on. So lactate, one from the very essential tissue biomarker for the perfusions. Moreover, lactate correlates well with both macro hemodynamic as well as tissue perfusion. Many studies just to compare. With higher lactate, more patients will die. As you can see in this study, survival only 30% when lactate more than 3.5 millimole per liters. And if you are targeting lactate during your management, less patients will die. Not only the figure of the lactate clearance. Lactate clearance, you can see it here with days. Probability of survival will be higher if you clear your lactate earlier. So please, I don't like to say don't forget, because one from the essential to deal with is the lactate with the patient in shock. The second biomarker is central venous oxygen saturation, or we can say mixed venous oxygen saturation. It is indicator of the balance between oxygen utilization as well as consumption, supply and demand. So when you have the equation to this is mixed venous oxygen saturation, you can have four determinants. If you look at them, it is saturation, oxygen consumption, cardiac output, as well as hemoglobin. This is common equation in the hemodynamics. If we did fix the oxygen saturation and hemoglobin and the oxygen consumptions, cardiac output would be correlated with the mixed venous oxygen saturations. There is difference between mixed and central venous. So it's not the time now to go in depth what is the difference between both of them, but you can find them, both of them correlated. And many studies and meta-analysis showing there's a good correlation between mixed venous oxygen saturation and central venous oxygen saturation. Right? So we talk about central venous oxygen saturation now, and it is a very good marker to give you a clue about the balance between supply and the demand. So let us put it in the flow chart. If you have the patient, so again we said the balance between delivery and utilization. If you have low mixed venous oxygen saturations, so almost either due to decreased delivery, due to hypovolemia or low cardiac output, or increased consumption, like the patient in seizuring or shivering. If you have the patient with high venous oxygen saturation, just take EBG and check how much the saturation. Either delivery will be high with hyperdynamic circulation, with more fluid, with more entropes, or utilization will be low with the patient who is in sedation or hypothermia or shunting at the end of the sepsis. So central venous oxygen saturation you can rely on to give you clue about the balance between utilization and delivery, but not the quality of the perfusion at the level of the tissues. Yes, it can tell me I can increase the cardiac output to improve the central venous saturation, to improve the delivery. But how is the quality on the level of the tissues? Carbon dioxide gap. Yes. Carbon dioxide gap can be used to monitor the microcirculation. Look at this graph. One from the most common mechanism of shock in sepsis is heterogeneity. What is heterogeneity? As well as edema. Heterogeneity is, this is the microcirculation. We have microvessels, which is well perfused, and another neighbor vessels, which is not perfused well. This is heterogeneity, one from the most common mechanism of septic shock patient on the level of the microcirculation. If you can see it here, the area which is not hypoperfused, suppose carbon dioxide coming from the arterial side in the area of not perfused, carbon dioxide is supposed to be accumulated here in this area. We call it carbon dioxide stagnation phenomena. It will be accumulated here. But fortunately, the solubility of the carbon dioxide is higher than the oxygen. So it can travel faster and more far than the oxygen. So on the level of the venules, carbon dioxide can move from the hypoperfused area to the veins, increasing the amount of the carbon dioxide on the veins rather than the oxygen. And you can think also here, if you have tissue edema, which is very common to have your patient with shock and tissue edema due to leaking of the endothelium, right? And the glycocalysis disruption. This tissue edema increase the distance, diffusion distance. Carbon dioxide can travel faster and far away from the oxygen. So here the principle, if you are measuring the difference between the arterial side and the venous side of the carbon dioxide, you can find it high because carbon dioxide can diffuse more far than oxygen in the hypoperfused microvessels, give you this amount of the carbon dioxide gradients. I'd like to thanks and appreciate one of our colleague, Dr. Zainab. She just published 2 days back this meta-analysis about carbon dioxide gap in critical ill patient systematic review and meta-analysis in critical care medicine. She's working now in Canada, and she's from King Faisal Specialist and Research Center, one from our colleagues here in Saudi Arabia. Very nice meta-analysis, still in the online. She found that patient with shock stage, mainly the medical and surgical ICUs, high carbon dioxide gap associated with increased mortality with odds ratio 2.2, as well as higher lactate level, low cardiac index, and central venous oxygen saturation. And very nice statement I do like in her conclusion. Shall we target carbon dioxide gap closer for the station of the patient with shock? Yes, and it needs further area for research. If you are closing the gap, your patient will improve. I hope so to confine this research later on. Again, another flow chart. Let us put everything together. If you have the patient with high lactate, so what you will do, just take a look on central venous oxygen saturation. If you did find it less than 70, one of the four, if you remember the equation, either we have problem with the increasing oxygen demand, like pain, like temperature, so this patient need analgesia or antibiotic. If your patient have low hemoglobin, just try to correct. 7 is enough, unless your patient have acute bleeding or ischemic heart disease, you need to go higher to 9. If you have the patient with low oxygen saturation, this is the cause of the central venous oxygen saturation low, just increase your FiO2. Try to increase his oxygen delivery. If your patient has fluid responsiveness, give him fluids. If he's not responsiveness, give him inotropes. Right? Until central venous oxygen saturation going higher, more than 70. Please take it one by one from the sedation, anemia, hypoxemia, then fluid responsiveness. Don't rush to the fluid responsiveness without assessing the fixed parameters you have, which is affecting central venous oxygen saturation. If you did find your patient with high central venous oxygen saturation, at here, you need to look to the microcirculation. In this stage, you can take a look here. This patient have normal MAP, but he have problem with the tissue mark with the hypoperfusion indicators. We don't have problem with the macrocirculations. So such patient with high central venous oxygen saturation, consider carbon dioxide gap. The normal less than 6, between 2 to 5. If you did find it more than 6, almost. Further increasing cardiac output can improve the oxygen delivery, can clear more lactate in such case. If you did find it normal gap, at that time, you have to disclose. No benefit from high cardiac output. Search for the definitive management. Wait for the infection to be treated. At the end, take a look to the lactate after 2 hours. If lactate is cleared more than 20%, you are in the proper way. If not yet, go back again to the chart and reassess again the same chart. And another message, if you have the patient with normal lactate, whatever central venous oxygen saturation, don't go further. His normal patients, right? Of course, you have to exclude another factor of the hyperlactemia. We are talking about lactemia due to hypoperfusions. So this is a very nice flow chart to give you a clue how to deal with the tissue biomarkers in consequences. Those on the level of the cells. What about the microcirculation? Yes, this is another dilemma, another part. It needs another lecture. I hope you have to have. We can have it specific for microcirculation. Many techniques. Again, static also dynamics, direct and indirect. The most common of it is direct visualization of the microcirculation using cytochem. Of course, many literatures coming, and also some guidelines to tell us about the consensus in 2018, updated by the those figures, the Kanenchi, and as well as the Baker, all of them they have some recommendation using microcirculation parameter assessment for the patient with shock stage, right? And many editorials published, shall we use it microcirculation parameters as a target for resuscitation of our patient? Some of them said yes, some of them said no, but I'm saying I'm going with Xavier Monet, which he said not yet well developed. Yes, pathophysiology, we agree that coherence has to be between macro and microcirculation. Microcirculation has important part in the shock stage, but technology and the therapy still going researches, and we need to be in clinical practice as much as we can. Almost, I touched most of the 3 phases of the shock stage on the level of the cells, as well as microcirculation and the macrocirculations. But at the end of the day, whatever your choice, whatever the company promoting its device, whatever you have any parameters in your ICU, when you're dealing with shock patient, just remember the first one. Very funny. A fool with a tool is still a fool. As I told you earlier, the first and the most important one is a physician. If you cannot interpret it, nothing will be done. Hemodynamic parameters will never improve outcome by itself. You have to have the insight and the interpretations and the intervention to improve based on the hemodynamic tools. Another important message, no one size fits all. You cannot drive your car in different road with the same speed, right? I cannot say when somebody telling me the normal cardiac output is 5 ml, 5 liter per minute. The normal MAP is 65. No, I don't have normal. I have adequate. I have parameter which is fitting me, not fit you, not fit the other one, right? So please, if you have adequate parameter, this is the normal of these patients. Don't think usually the higher is the best. No, higher cardiac output is not the best. Higher central venous oxygen saturation is not the best. It looks like you are striking the tired horse. Don't give more in troops. Don't give more and more and more. And of course, dynamic is always better than statics, as well as continuous is more preferable than intermittent. Of course, invasiveness is essential, but is not the only issue to think about it. The highest invasive technique, still there is a place for it. The last message, hemodynamic parameter is not a single parameter. You have to integrate, you have to combine all the variables you have, and you have to collect your puzzles. For example, oxygen utilizations, spectroscopy, central venous oxygen saturations, tissue perfusion parameters, oxygen delivery parameters, macrocirculation parameters, collect all to reach to your target. At the end, thank you so much. I hope I delivered a message. Hemodynamic, it is an art. It is a tools. Please use it properly. Without you, nothing will be done. Thank you so much.
Thanks so much, Prof. Madi, for this lecture, as usual. So I have 2 comments quickly until we get enough questions here. So the first one is I actually expected to hear something about endothelial glycocalyx, the new theory of separation between the microcirculation and the macrocirculation, which is the difficult cornerstone in the management. We can assess the macrocirculation, but we cannot really assess the microcirculation, and the theory behind endothelial glycocalyx is coming too fast in the last 2 or 3 years. So what do you think about this theory, and how practical we can approach the microcirculation depending on this theory?
I'm totally agree, of course. Glycocalyx, yeah, by the way, my son was studying the first year of the Faculty of Medicine. He was studying glycocalyx. I told him, oh my God, I am now in the 50s and I'm just knowing about the glycocalyx. Glycocalyx is something which is coming over the last 10 years. All of us know from the, what I was studying in the Faculty of Medicine before, they are giving us 2 important factors affecting the filtration or reabsorption of the oxygen at the level of the tissue and the microcirculation. One of them is hydrostatic pressure, one of them is the oncotic pressure. Those are the main two components we have for diffusion of the oxygen at the level of the microcapillaries, right? But really, they have now another very, very important force, which is the glycocalyx, the very thin protein layer covering the endothelium. They did find one from the very important mechanism of the septic shock patient disruption of the glycocalyx. It plays a very important role in the leaking of the fluids and the blood from the fluids and the molecules from the microcirculation. Agree with you so much. Not yet in practice of the clinical practice, but there are some researches targeting glycocalyx integrity of the glycocalyx and management of the patient of septic shock. All of us knew that normal saline have a lot of debating nowadays worldwide, right? They mention it now as abnormal saline, not normal saline. Why? One from the drawbacks of normal saline, it's causing disruption of glycocalyx. So they are searching now about the components or the intervention which play a role in maintaining the integrity. For that, even if you are following up with the fluid management of the patient with septic shock, there is some space for the albumin. Why? Yeah. Because not only oncotic pressure, no, but because it can maintain the integrity of the glycocalyx. It's play a role. I hope they can find the proper way which can help in maintaining its integrity. Very, very advanced. And thank you, Walid, for this point. But the time is limited to go in details about it.
Yes, perfect. So until we get a few questions here, I'm putting the poll to document your attendance. So first question is, I think there is a bit of confusion here from Ali Saad. He said, is the passive leg raise test is more sensitive and dependent than ultrasound or echo, especially if not available for septic patient? I will comment first, Dr. Ahmed, and then give you the mic. So the passive leg raise test is not either or with echo or ultrasound guidance. This is an area of interest for myself. So you can combine LVOT, VTI, or ultrasound guided approaches with the passive leg raise test. So it's not either passive leg raise test or ultrasound or echo guidance. They can be combined together to give you more sensitivity and more specificity. I mean, you are targeting certain patients. If you have good responsiveness, VTI responsiveness, or pulse pressure variation responsiveness, or stroke volume variation responsiveness, and then do a passive leg raise test, and you find there's a good response after the passive leg raise test, provided you do the passive leg raise test in the proper way, this is the time that you consider it positive passive leg raise test. And the mic is yours, Dr. Ahmed, if you disagree with me.
Totally agree with Walid. If you remember my slides, I'm telling all fluid responsiveness tests based on something, which is you have parameter to measure, and you have intervention after this parameter, and you measure this parameter again, right? So passive leg raising test, it is the intervention you are doing in between. So whatever you are measuring before and after, it can be. You are measuring the stroke volume before and after. You are measuring descending aortic flow before and after. You are measuring the pulse pressure variation. You are measuring heart rate. You are measuring the systolic blood pressure. You are measuring IVC. You are measuring whatever you are measuring before and after. It doesn't affect the test. So what did you change here? The intervention you did. Why we change it? Because we have many limitations for the mechanical ventilation cycle. It changes during inspiration and expiration, like low tidal volume, like high intra-abdominal pressure, like arrhythmia. So you are searching for another intervention not affecting by those parameters, which is autologous, reversible transfusion of at least 300 to 500 ml of blood, of his own blood during his shock stage. Thank you so much.
Perfect. So I would really like to switch to the next lecture, but like the questions here are really good questions, and I will give 5 minutes more asking Dr. Amr Salam the forgiveness for this delay. So the first question is a continuation for the last question from Mahmoud Al-Muhassab, and I know him in person. He's asking about a patient with a pulse pressure variation or stroke volume variation cannot be used to assess fluid responsiveness. what is the alternative? Passive leg raise test is used when, like how to assess the cardiac output. I would say, like what's my school doing is a mini bolus and assess for difference in whatever technique you started with, like pulse pressure variation, stroke volume variation, cardiac output, whatever the technique you used, you can give a mini bolus of 250 mils of any crystalloid or any colloids and follow that up, because some people, like traumatic brain injury or high ICPs or whatever, you cannot do a passive leg raise test for them for other concerns. So do you agree with me, or you have any more ideas?
Sure, I did agree with you, but I have a message here for all of you, because fluid responsiveness is a big dilemma in the literature and everywhere, right? So whenever you talk about the hemodynamics, you are considering fluid responsiveness is something like the top of the hemodynamics. Please, fluid responsiveness test rarely to be positive. It is not the standard, especially in the ICU. Okay, great. Usually, the patient coming to you in ICU with he received most of the fluids everywhere, late stage. Responsiveness, it doesn't mean your patient he's requiring a fluid right now. We have another limitation, different dilemma. Because most of you are anesthesia, yes. The variability of the passive leg raise test or whatever the fluid responsiveness in anesthesia patient, because you are the first skewer to him more than the ICU. So timing of the fluid responsiveness, very essential. As Walid mentioned, whatever the intervention, fluid challenging, index expiratory occlusion test, passive leg raising test, just to give a fluid challenging for the patient to assess the parameter before and after, it can be enough for your patient. But don't do it even if you will do for yourself now, passive leg raising test, it will be positive. Every one of us. It does mean you need fluids? Of course, no. Why? Your heart will respond. But the heart of septic shock patient, it can respond. It can respond. But in certain limit, you will fail. Again, it is good assessment. It's very good media for the question everywhere, in all exams, by the way. So study it well, but when you practice it, be wise. Thank you so much.
The last question here, for sake of time, by Ahmed Kuhail. What is the best or better for closing the carbon dioxide or CO2 gap? Is it the nitrogen or the butane, Dr. Ahmed?
Yes. Ahmed Kuhail, one from our eminent fellows, by the way, and I do like his very, very good and highly hard worker. He can notice in my round, I do love to give the vitamin for such patient at the end when blood pressure is tolerating, just to clear more of lactate, to increase more, to improve the heterogeneity. Many trials done about the vasodilators, even nitroglycerins, even the vitamins, even nowadays they are doing with elioprost. Even the beta blocker have a rule for improving the tissue perfusion at the level of the microcirculation. All of them studied, but not yet as solid enough to practice it as a routine or a standard of care, right? So you can use all of them, yes, but still, it's not in the matter of the higher recommendation or high level of recommendation.
Perfect. So the last thing I would like to review with you, Dr. Ahmed, in one of the slides that you mentioned, if the patient is initially an echo, if the patient is normal cardiac function or abnormal cardiac function, I would consider any patient with sepsis or septic shock, as per one of the systematic reviews, is at least grade 1 diastolic dysfunction suspected. So I cannot consider any patient with good contractility and normal cardiac function. We should consider systolic plus diastolic dysfunction as well. So we need to be very careful. We need to get an idea about the echo, how to assess left ventricular systolic function, left ventricular diastolic dysfunction, good proper assessment, or like proper assessment before you judge it, good cardiac function before we go ahead. Do you agree, Dr. Ahmed, with that?
I don't have something to say with the experts of the echo and the expert of the, when I'm presenting hemodynamics, the part of ultrasound and the echo, I'm keeping it aside. I don't like to touch so much because I know the people who's expert in this part, the more expert than me, really. So, of course, I am attendee in this one. I'm not the speaker. Thank you so much.
Thanks, Ron. And if you want to add something after the cardiac assessment, you can use the lung ultrasound on the lung basis to detect if any extravascular lung water as another non-invasive tool. It can be used in the ward, it can be used in ED, ICU, it can be even used in home by some paramedic technicians that are trained enough for that. So it's non-invasive, it's a quick tool. You are losing nothing for using that one. So basic echocardiography and lung ultrasound are good helping tools in this aspect. My full appreciation, Dr. Ahmed, for this very nice night and this comprehensive talk. And I am never satisfied enough or never saturated enough with your talks, but I like it's for sake of time. Thanks very much, and you can stay with us. There is few more questions if you can answer them in typing in the Q&A section from Fatma Al-Hammadi, Alauddin Mitwalli, and Muhammad Hassanin. Just for sake of time, we'll go for the next speaker here. Thanks so much again, and my full appreciation, Dr. Prof. Madi. Our second speaker is Dr. Amr Salam. Dr. Amr Salam is currently a lecturer in Ain Shams University. He has his Master of Science and MD from Ain Shams University. He has finished European Diploma of Anaesthesia and Intensive Care called DISA, and he's cleared also his Irish Fellowship of Anaesthesia, and he spent 1 year of fellowship in neuroanesthesia. Dr. Amr is not his first time to be our guest in Anaesthesia and Critical Care Refresher course. He's one of our eminent speakers, as all the times, comprehensive lectures, and with very interesting topic tonight. The topic is awake craniotomy. I think it's available in many exams now, so it's high demand topic. So please, Dr. Amr, start sharing your presentation. Dear attendees here and colleagues, enjoy the lecture. Thanks very much.
Thank you very much, Dr. Walid, for the brilliant introduction. Thank you, Dr. Ahmed, for like comprehensive and lovely lecture. In fairness, I totally enjoyed it, and I don't mind to keep listening to you talking about that lecture anyway. We're moving to more specific and more highly specialized topic, which is the awake craniotomy. And talking about awake craniotomy it's like an important topic in neurosurgical anesthesia, and it's some sort it's aimed now in the exams to be mentioned and to be discussed. And usually in the practical life, when you know that you have a patient for awake craniotomy, you have questions to ask. And I'd like just to discuss some of these points with you. First is, what is the awake craniotomy? Why for this patient we have to, and where we're going to do that exactly at any site of the brain, and which patient we're going to aim and which patient we will be exclude, and how is that the main topic and the main thing we will talk about, and then when. I'd just like to ask you first a question, is how many awake craniotomy you attend? If you can answer that question, Walid. Now, can we get the results?
Yes, more than 60% never seen.
Okay. So if I'm telling you that I have attended more than 20 cases, it's literally 23 cases. And I'm not bragging about that. It doesn't make me an expert, because every now and then when I know that I have an awake craniotomy in a lesson I attend, I'm still scared. I'm still worried. I still start to read everything I have on that. I have a folder specific for awake craniotomy. And then let's talk about that clearly in a very slow way and very easy way. So what is awake craniotomy? The name itself is not totally right. It's not correct. Craniotomy is to make an opening in the cranium or the cranial wall, and that is not done. Usually, craniotomy is performed under sedation. Why it's called that name? Because we got that from the old nomenclature of the whole procedure while we're doing craniotomies awake for Trifine or something like that. we all have attended a lot of lectures about awake craniotomy. I was asked by Waleed to present the video for the thing. I did that for him, but I just like to, for the next slide, just to take a look to the anesthetist. Don't mind the patient himself, just mind the anesthetist and see how he looks like, how he deals with that. That's in South Africa. This is a musician, a famous one there. He's a jazz singer, and he had a brain tumor, and they are asking him to perform on his guitar.
I'm afraid there's no sound we have here, Amr.
Yeah, it hasn't started.
Okay, it started. It did not start playing yet. Okay. Sorry.
Yeah, he's just moving his finger. No, I'm more concerned. I was telling you, Waleed, most of people have shown this video for patient who's undergoing this procedure. Yes, but for us, it's totally different aspect we are talking about. It's for my professor, it's an easy day. It's an easy procedure. Yes, we will be concerned as any normal day. But for me, it's still a very frustrating, a very difficult day. Actually, it's weeks more. And I'll tell you why. Why we are doing this surgery? And you're asking yourself this question. And we have all known about the eloquent areas in the brain, which is the highly functional, relevant areas of the brain. Any tumor close to that, like the one we chose, this is a functional MRI showing a brain tumor on the right side, on the left side. And this brain tumor is very close to the temporal area. And these red zones is done when the patient was asked to whistle. And that really shows how very close the tumor to that one. Other procedure we can do, like for epilepsy or a deep brain stimulation for epilepsy surgery with electrocorticographic mapping. Minor intracranial surgery as well might be done awake, and that will be an awake craniotomy, or even with a vascular lesion that was very close to the brain tumor or the eloquent areas. And then we'd ask ourselves, why we prefer to do that? Do we prefer to do that, in fairness? Yes, awake craniotomy has some advantages. It minimizes the disabilities that we got, and we will show you a study, one of the famous studies in the neurosurgical anesthesia about this. It minimizes the disabilities that we expect, unless we'll see it after later. It might happen still. It will maximize the whole excision of the tumor from this area, leaving nothing to lead to recurrence afterwards or something like that. Yes. A side benefit as well is to reduce the general anesthesia complication, which is a little bit common with the neurosurgery, like pulmonary infection or something, or urinary tract infection, and that will help with the early discharge as well. And for us as an anesthetist, our goal mainly is to patient comfort, and this is why we administer the sleep thing. It can be done awake with the local anesthetics, yes, totally, but our aim is, one, to keep the patient more comfortable and to avoid complication and to treat it when it happens. And this is the study I'm going to talk about. It's one of the famous studies performed in 2011, and it showed this compared between general anesthesia and awake craniotomy for patients for supratentorial lesions. And here it shows in that table that there is no difference between the operating room stay or the duration itself, while the total removal percent of the tumor. And as you look like to the slide itself, it's yes, it's 37%, while in the GA is 52. But if you take a look to that group, which is a GA 72, which is a 72 patient that won't be able to perform an awake craniotomy for them, although they are very good candidate, this percent is huge. It's more than double, and the subtotal removal as well. The other thing is the complication. We'll discuss that. But just to show you the number, and still we are comparing between the awake and the GA72 group. The difference, the percent is huge as well. So awake craniotomy provides us. The most important thing is the survival graph itself, showing the mortality rate, which is far way less in the awake craniotomy, especially with the patient with the GA. Yes, we can talk about that a lot, but I collected most of the data from other studies all through the world, comparing between the awake craniotomy and GA group, and all of them shows the same thing. There is a little bit even a difference between awake craniotomy in a patient who is indicated, except if it's compared with a patient who underwent a GA for that. Now, let's talk about our patients. What's the challenges we are facing? Specifically, I'd like to divide them in two main problems, which is agitations and airway compromise. Anything else can be managed. Anything else, it won't be a huge thing for me. But agitation that might led by the length operation itself, the time he would be kept awake for that, if there is any adequate sedation, inappropriate sedation choice, and this is very important as well, and we'll see, and the analgesia. While the airway compromise, that's when we use a propofol more or something that will affect the consciousness of the patient and lead to airway compression. Now, I know that 60% of us hasn't attended any awake craniotomy, but mostly we have read about it. We attended more lecture. I'd like to ask you the next question and see which patient is least suitable to have an awake craniotomy, in your opinion. Is it a 10 years old child? Is a patient with a BMR of 30, patient with a Melampathy 3, or a patient for a recurrent glioma, or a patient with a Down syndrome? Oh, right. Yeah, so most of us agreed about the 40%, about 40% for this patient with a Down syndrome. Although I'd like to discuss, 10 years old child is a small, and we will discuss that later. It's a very young to be cooperative as well. Yes, there is a cases has been reported to be done for a 9.5 and 11.5 years old. Exactly. These are the two cases I heard about. BMI 30, yes, it's not a huge patient to avoid, like to avoid the sleep apnea or something like that. And the patient with the recurrent glioma, yes, recurrency, it's not a contraindication for awake craniotomy. It's more because of the diffusion of local anesthetic that we are worried about because of the fibrosis and the technicality and the difficulty in the procedure itself that might lead to switch it again to GA, which is a very difficult decision for us in the procedure itself. Now, let's take a look to our patients and which patient we gonna choose. Actually, neurosurgeons usually choose these patients, and will get them to us and ask them, are they eligible to do an awake craniotomy? Please, this tumor is very critical and he's performing or something like that, and that will affect his motor function, his speech, or even his visual functions. So, and we have to discuss a lot of that preparation for these patients. But like to look to these patients, usually we tend always aim for a awake conscious patient. He's not agitated. He is not in a drowsy state. It's always conscious. Cooperative. Cooperative patient is a very important. And that means the level of education that you will need to achieve for these patients. This is a process, a long process to achieve with the patient through 2 to 4 weeks to teach him and to learn with him what he makes him comfortable and like that. And the communication. We are living now, most of us live in a multicultural communities, and we might need a patient with a different culture, with a different language, That would be a big and a huge issue for the anesthetist to deal with. As we see, even as a native speaker, Arabic speaker, like the English speaking, we are fluently talking, but still we have some limitation. You can imagine that with a patient with a different language that he is suffering as well, either with like from another country or something like that, or he doesn't understand even English or Arabic. How you will deal with that? You have to think about it, and that might change even the decision for that. And then the medical things. I think that the most three important things is the first three things. If the patient is conscious, cooperative, and you were able to have a communication with it. Airway is an issue. And of course, managing the airway with the Mayfield on this patient make it far way more difficult. We haven't reached to a solution to solve that. And we'll discuss that later as well. But still, the airway, if you have a suspicion that this patient has a difficult airway, or you have the patient's document that mentioned that the patient is a difficult airway, it's preferable to do that under GA after securing his airway. Bleeding disorders, it's if this patient gonna bleed due to either the tumor site, the tumor nature itself, or even for any reason, a medical reason that will cause him to bleed, it's better than that to avoid an awake craniotomy. You cannot manage a shocked patient in awake state. You have to still intubate him. And then seizures. Yes, I know most of these patients manifest with seizures, but like they should be controlled, and it's different between the whole institutes. Every institute has a limit. Our institute gives 2 weeks free of any seizures, very well controlled. Other institutes I've worked before, they give it like 6 weeks. That they are saying that the management of the anti-epileptic management is full, and the patient doesn't have any form of seizure, any form, and literally any form of seizure in these patients. Just the patient age. When I'm talking the patient age, I'm talking more about the size and weight of the patient. We'll discuss that. Young patients specifically is very difficult to manage. It's not by the mentality. You can manage and deal with an 11 years old patient or even a 9 years old patient, but still his weight for the local anesthetic, that will be difficult to manage doing all of these techniques, so local anesthetic techniques, to perform with the limitation of the volume itself, and that involves the weight as well. The tumor, and that's a discussion, that's an MDM happens between us, the neurophysiologist and the neurosurgeon, to decide. Frequently, but not always, it's used for gliomas like glioblastoma, astrocytomas, oligodendromas. Some tumors we suspect that they are more vascular, they lead to more bleeding, and that will be difficult to manage in that. Some tumors as well, the nature with an invasiveness, we have to decide and to be sure about the grade and the nature of the tumor itself, because if we open and start to open and perform an awake craniotomy in a patient, and we said at some point that we are not able to excise it, that will be a disastrous, and that will be very difficult. Location of the tumor itself, we are trying to perform to excise tumors mostly in the frontal and temporal areas. That's because the patient cannot be done in a beach chair position or in a sitting position or in a prone position. So tumors that had a difficult to be accessed through these like supine position or even a semilateral supine position, yes, we have to avoid these to be done in awake craniotomy. We tried, and I have attended once, to be done in a beach chair, which was a very difficult surgery. It takes us about more than 5 hours, which usually these procedure takes about 3.5, sir, but like 5 hours, and that was very risky. I was just in my starting my practice, so I was very junior. I didn't understand that, but my consultants approved that as well. And here we're gonna talk about the recurrence of the tumor itself. And as I said, you can perform a recurrent tumor, you can excise a recurrent tumor with awake craniotomy. There is nothing to worry about, except the fibrosis that will affect your diffusion of local anesthetic, starting from the scalp, starting in the brain tissue itself, and the anatomy disfigurement that will happen, and it will appear in front of you during the surgery, make it more difficult as a technicality. I'm just here sharing this this case report, which is an awake craniotomy in a child, and they simulated the theater experience. It's a very brilliant paper. It showed how they dealt with a child, and they had to perform literally like an hour or more of a simulation of the surgery itself to see how the patient would cope with that. Now let's go to talk about the techniques and how it is different. We are still talking, we're still keeping the same categories we have. We have the sleep awake sleep technique, which we call it SAS, which is either using a JA or a sedation. The sedation either is like a deep sedation with a propofol or rami or just an dex as well. You can use that, but still, and that was introduced more with the using of dexmedetomidine, is the awake technique, that keeping the patient awake with just with the monitored anesthesia care and keeping the patient more or less a little bit sedated with a Ramsey score between 4 and 6 to keep the patient. GA, some of us had been used an ATT tube, like to intubate the patient, put the patient in a fully asleep, and then extubate the patient when we need to do that. The LMA was introduced recently for in the whole practice of that, not recently for us, of course, which facilitates more and easily recovery with that. There is a paper discussing every single thing, from using an inhalational anesthetics, maintenance, and even a TIVA for that procedure. And there is no, I'm telling you from now, there is no one is superior over the others. The most important thing, and that's I would like to focus and to say it clearly, that the most important thing for these patients and for these surgery to succeed is preparation of that. And that will take us to this quote by Benjamin Franklin, which is, by failing to prepare, you are preparing to fail. Preparation of these patients is a very long procedure. That's the usual patient preparation in theater. Some of my patients, I might them in the operating theater, in the induction room, or in the reception. I'll meet them for the first time, we'll have a discussion, or even at the night of the surgery. But with these patients, with awake craniotomy patients, we usually ask for them to meet them, and the specific anesthetist who will put him asleep will talk to him and have a very intensive dialogue about the whole procedure, including videos, including layouts, showing him a lot of documents. And usually we meet him with one of the relatives just to be focusing with him and just to keep him in our state. We have to learn the patient. We have to know the patient himself, and we have to teach the patient as well. Usually the first meeting will include will be 2 hours or less, explaining the procedure, explaining every single step from the night of the surgery up to the morning, and how the procedure will go. And what we're gonna talk about, these are the points what we're gonna talk about. That he will be resting or sleeping on a bed for about 1.5 hours or more. Stay still, he won't be able to move. And if you even try that by yourself, you won't be able to do that. Actually, we ask the patient themselves in these 2 weeks to train themselves to try to stay still on a floor, not on a bed, because the floor is less comfortable than the bed, to stay still, not to move for a longer duration till they achieve the 1 hour or 1.5. And that by that, they will detect even the sources of discomfort they will feel in their body. The hip, specifically the knees, or even the heels, all of these points have to be taken into point. Is he going to use his glasses? He will need that if we're testing his visual acuity. Are we going to need that, or we not? Can he deal with the whole environment, seeing it not clearly or not? And then about the fasting and use of alcohol and nicotine. And this is a little bit a tricky point to talk about. Usually we encourage the patient to stop everything before the procedure. But can you imagine a patient who is agitated, who got a withdrawal symptoms or syndrome that's a day-night or the day? Some of the institutes will encourage the patient to maintain his normal routine dealing with an alcohol or nicotine until the night of the surgery, and that to avoid the withdrawal symptoms, even the minimal withdrawal symptoms. And for any smoker person, he would know that stopping smoking for 12 hours or less, it might cause an irritability to him, and that's what we don't need during this procedure. And for the fasting, we usually ask the patient to have a drink of clear fluid when they are preparing him to send him to the ward. That will give him more than an hour or hour and a half fasting, and that would be enough for us. That's the most important thing, is to keep the patient as comfortable and to let the patient know that he is a part of a team. He is our concern. He's our main concern. He's our aim to comfort him, but he is a part of a team. And always these patients are very encouraged, and they are not by any way reluctant to perform anything to help these procedures, because they know that's very important and how the success rate. That's how we're gonna talk with the patient. It will be, and we'll keep him on that trolley for a while, just to let him know how. And we encourage him even at the night to sleep with a 20 or 30 degree elevated, because that will be the position we'll keep him in that. Now for the next question, the patient medication. Which of these drugs you think will be continued for awake craniotomy and we will stop it, or you think we will stop it for a general anesthetic?
Let me make use of this 30 seconds, Dr. Amr, and highlight, as you mentioned, simulation training of the kid in the child study. So sorry for the interruption, but it's just to make use of these 30 seconds. Prof. Abdulaziz Walker will be our guest talking about the impact of simulation in anesthetic practice next Saturday. So I would advise everyone to attend. So thanks.
Mm-hmm.
Can you see the results, Dr. Amr?
I can see the results, yes. It's like 35% will say will stop the anti-epileptics. And sorry for that. I'll totally disagree with that. We'll keep every single medication or stop every single medication as we are dealing with the GA. So if a patient was capped with ramipril, we prefer to stop that prior to the surgery if his blood pressure is controlled, or change it to amlodipine or something like that. But we won't stop any of his AEDs at all, specifically the anti-epileptics. That's maintain his level of that. And that's a very important message to take home, we will deal with the awake craniotomy as any other procedure performed under GA. We'll stop the medication for that. Now, we got the patient, we got him in the hospital on the evening of the surgery. We'd give him lorazepam, 1 to 2 milligram, to give him a quiet night and a good night rest, which is important. He will be very stressed. He know that he will gonna perform a brain surgery. That's a very important thing. We'll ask the patient to keep sleeping and to give the patient anti-thrombotic stocking. It's very uncomfortable stockings. And we usually have to measure them before the procedure, the assessment clinic. And if we are able to give them these before, just to use it and to avoid if there are any nicks or something in that will make them very, very uncomfortable. In the morning of the procedure,
if you just repeat the message from the last slide, the sound was very interrupted. I didn't get your message clear. Just in brief. Thank you.
So yes, so the patient own medication has to be kept. And as we are putting this patient asleep under GA, so if we're avoiding ACE inhibitor or ARBs, this is our situation. Institution, we have to stop them because we might need to give this patient GA at any point. We won't stop his anti-epileptics for any reason. Keep that, keep the patient having seizures before procedure. And on the evening before the surgery itself, we give him the lorazepam just to give him a good night rest, ask him to sleep hard a little bit, like 30, and with how much exactly, 30 degrees. And we'll give him antibiotics because they are very tight, they are very uncomfortable, and we'll give them that, and they will use it as well. So in the morning of the procedure, about an hour before the anesthesia induction, we'll give him promethazine, which is one of the first generations to make him more sedated.
Sorry. Can you hear me?
Yes.
Like
it shows that we have.
Yeah, we lost the sound either completely or there was a lot of interruption from the last.
Yeah. I feel that. I see that. Can you hear me clearly now?
Yes, now I can hear you very clear.
Yeah, I cannot hear you clearly, so I'll keep talking. I'll try to talk slowly a little bit. So
yeah, it's fine. Now I can hear you clearly. Can you hear me clearly now?
Yes, yes.
Perfect.
So yes.
Just to summarize the last slide and this slide, please. Thank you.
Again, the last slide.
Yes. Like it was interrupted for the second time.
Oh.
Like okay. from the middle of it.
Okay. So again, I think this message is very difficult to deliver. So patient's own medication has to be dealt as we are putting this patient in a GA. So we usually stop it before, like ACE inhibitors or ARBs. That's no problem. We'll stop that. But anti-epileptics or any beta blocker or calcium channel blocker, we need to keep that. And we'll discuss that later in a while. In the morning of the surgery itself, before the anesthesia induction, we'll give the patient some sort of first generation antihistamine to make it safe. We are one people who's not using midazolam. I know a lot of people prefer that. I don't have any conflict and interest with midazolam. But I think, and a lot of people who's dealing with a neurosurgical anesthesia think about that. It's not the best agent. It might cause control of everything, so we'd avoid that as maximum as we can. Other medication we can give antisalivos like a glycopyrrolate, ranitidine, metoclopramide. I don't give metoclopramide a lot, but like a lot of people will do that as well. And then we'll start with Usually, all awake craniotomy patients are planned to be the first to minimize the whole problem with fasting and everything and organization. And we'll try to use what the term which is called a vocal anesthesia. That while we're keeping the patient awake, we'll try to calm him, just to talk to him, and to explain every single bit. Like we are attaching a lead for ECG. We are putting that on your finger to measure every single thing in a very calm way to keep the whole environment very clear, very quiet, and easy to deal with. You can imagine that you are getting in a bed in a totally different environment you haven't seen ever before. And then we start with monitoring attached IV axis like an 18 gauge or a 16 gauge cannula and put him in a nasal cannula, and then we'll start our induction. Yes, that's the way we call it: asleep, awake, asleep, awake, asleep. And this is induction is performed either with any way, but I prefer still. I have used propofol, which is a bolus of 0.5 to 1 mic per kg, and then continue to use about 4 milligram per kilogram per hour, or in the TCI to keep it between 1 and 2 microgram per deciliter. Both of them are fine. And under local anesthesia, we'll try to put the arterial catheter, the central venous line if you need one, and the urinary catheter if you need still. And I consider this moment is very important to test how is the patient will deal with the sleeping with the sleep state he's gone through, how he's deal with the painful stimuli, and how these sedation level is keeping him. That's one of the most important thing as well. After insertion of all the lines, we stop the sedation. And then we'll move him into theater. And you can imagine the number of the people is in theater. The minimum number you would have in a surgery theater is about 8 persons. Imagine the patient will wake up in that situation. No, we'll wake him up before letting him into the theater. That's why it takes longer. And we introduce everybody. Everybody will talk to him. Everyone will talk to him and clearly state what he's doing, what's that, to let him that's the team. That you are part of the team. You know where are you exactly, what we're gonna do. We'll attach like that and we'll talk to that. And from this point you start to talk calmly to him, to ask everybody to be quiet. And then we'll start our local anesthesia. And this is this is an issue, a point about that. Either we're gonna block the scalp block, which is very important to mention. It can be asked in an exam as well. But on the other hand, and it doesn't have any superiority over the scalp block, is to do local infiltration for every single thing and not to give the nerves block itself. Some surgeons would say, okay, that's losing about 20 or 40 mils of the local anesthetic that be given there, but like we would be very comfortable as an anesthetist to perform that. And these are in totally 6 nerves, and they are starting from medial to lateral supratrochlear nerve, which is coming from the trochlear notches, the medial aspect of the orbit, and the supraorbital, which is in the middle of that, and then the zygomaticotemporal, and then from the back of the head, it's the greater auricular and greater and lesser occipital, which is considered like you can block them at the same side. It would be very easy for that. On the other aspect, and even after we doing the scalp block, the question is to do that bilateral. Even if you are definitely sure that's unilateral, usually you will need to do that bilateral. Unless it's a very small incision, and I cannot promise you that you will ever see any one of these. Or to go and then start to give a local anesthetic preparation for the Mayfield clamp that will be given to the surgeon, that will be prepared by an anesthetist, because this is one of your job, is to assess and to measure how much the volume the patient can take, And that's why we're talking about the pediatric age group, that they are not able to get this number, this huge amount. But just remember, after administration of local anesthetic, you have to start your type of analgesia. A lot of people would use fentanyl, 25 or 50 marks of fentanyl to be given as a bolus, or will start the people who would use remifentanil will start the remifentanil from this point. And I can tell you now, just there is 3 doses and 3 ways. People will give it as a bolus, an IV bolus, and I don't encourage that at all. Or even to start it with an infusion between 0.2 to 0.5 mic per kg per minute, or even as a TCI. And that's the most important thing. The pinning is one of the most uncomfortable situations for all of us. And that the patient will need to know exactly. He hasn't to be sedated for this, because he has to know that from this moment, he is not able to move his neck, which is totally uncomfortable. Now, for the local anesthetics itself, starting from that, we'll give the local anesthesia to the surgeon, and he will start to perform that. So for the next question, which of these structures you think are insensitive to surgical stimuli? Is it the pia mater? Is it the dura mater? Is it the periosteum or the scalp? The vessels which is run through the pia mater itself might be surrounded by nerves. It's a little bit painful. I totally agree. This is the question from the exam, and this is the right answer, but still, we have to know that, because we would assume after the point of removal of the dura and picking it up that there is no pain, but still will be pain, and we have to soak it, and the surgeon will do that, and we have to ask him to be sure. And now, to continue through that, to continue during that, after the pinning and after with the surgical field anesthetized, all the blanks are installed, we start a sleep to put the patient to sleep again. And that's what we are talking about. Craniotomy, it's done while the patient is always asleep. We start with the propofol, while the remifentanil is still infused. We'll keep it imposed. We'll keep our eyes on the pressure at this moment, and then, because from this moment the patient supposedly doesn't have any painful stimuli, but still, so his blood pressure will drop, and that's something we need to worry about. And then after the craniotomy performed and removal of the flap and local infiltration, and as we said, local anesthesia soaked gauzes to have been done. And from this point, we have to discuss 3 main things in an intraoperative procedure. What will be, and we have to decide that clearly, what is the airway management will deal with in case of emergency. That's the points that has to be discussed and to be decided earlier. Are we going with the supraglottic devices like we would insert an esophageal airway once he's asleep, and that will help with his breathing with a nasal cannula, or we go with an LMA if we think that his ventilation is not enough to keep the CO2 and to keep everything, or we're gonna go for intubation. From the fluid management point, yes, we totally agree that we keep all of the patients are normovolemic, but what about the use of mannitol? And this is the point we had a conflict about that. We don't usually use mannitol for every single patient we have craniotomy. And that depends on the brain state and the brain relaxation state. But in these patients, we don't have the ventilation as one of ways to decrease the CO2 and help with the brain relaxation state. So with some of the surgeons and with some of the anesthetic consultants, we tend to give them mannitol from the start, and to put the urinary catheter from the start as well. And we have to accept from this point, if we decided that and we know that we will do, we have to explain the patient what's the problem with the urinary catheter, how he would feel it. and that he will feel the sensation and the urge to urinate, and that's only because of his pelvic muscle compressing the tube, and he has to relieve it, and that will dealt with, and that will manage how to deal with that. The other point, the third point I'd like to talk about is the drugs we will give. And dexamethasone, yes, it's some sort of brain protection, we used it. But we already know about the perineal pain that the patient have, awake patient, on the administration of dexamethasone. It's reported, there are studies done on that, and you have to decide that, and you have to explain that to the patient as well. Are we gonna give a phenytoin or something as a prophylactic anticonvulsant? With some surgery, it's a preferences of the teams, etc., institution. If a patient is liable to have a fits, and he mentioned that he had fits like 8 weeks ago or something before and he's still in the same management, we will give that. And at this point, the patient will be awake. When the patient's awake, he will be stressed and his blood pressure will be higher than normal, and that will might cause problems in the surgical field. And we have to know either we're gonna go with labetalol, the labetalol infusion, or as an ismolol as well, or ismolol as well. Then, once the dura matter is opened, the propofol infusion would be stopped, and then the patient awakening is expected. And for this time, we'll start to give them time to prepare the field itself and to expose that. Once they start, usually once they start to open, the dura will do that thing. And we prefer to do the brain mapping or the neurostimulation, what we call it, in awake situation. We know that the TIVA is preferred for the awake for the neurostimulation, but if we have the possibility of awake, because all the TIVA has effects on the neurostimulation. And the main problem issue and the main concern at this moment is having seizures. And we all aware that the first line of treatment of this seizure is flushing the field, the surgical field, with a cold saline that's kept cold beside the surgeon all through the procedure for any stage. Up to we can go for, I wrote the last thing, it's thiopentone. You can go to propofol, but like from this moment, you'd realize that you will go to convert the patient easily to JA. If you are not able to convert, we usually wait for about 3 to 5 minutes, and literally, I know that's a very long time. It's 5 minutes to for this procedure, and if it's not treated with a saline, we will go for the IV thiopentone or even a GA. Followed by that is the tumor section. While doing the tumor section, we're still keeping the dialogue with the patient. We'll keep talking with the patient himself. We will talk about him, we will talk with him, and we'll clearly, if he needs anything, if he needs to wet his lips, if he's feeling discomfort and need a position change, we will afford that in the limit. And that's why we are preparing the patient himself. And then this, when we start after the excision of the whole tumor, and we are happy, and the neurophysiological monitoring is done, everything is done, we start to close, we'll put the patient in sedation again. Now, just to talk very fast about 2 more points. One of them is the complication. What's the commonest complication of awake craniotomy discussed in literature, you think? So we have a 30% between respiratory depression and seizures, and we have the less percent is the new neurological insult, which is the right answer. It's the new neurological, you remember from the SACO study that we has discussed earlier about the complication. It showed that the neurological insults is more than the GA in the awake, it's more in the awake craniotomy than the GA group, as you see here, the percent. Although, if we compare that with the patient who support, and that we will answer that question, because these surgeries are done in very close areas which have these problems. That's why we are performing awake. But if we see if we compare it between the patient group who's supposed to have an awake craniotomy that had a GA, even they have a less total excision or subtotal excision, but still the percent is huge. It's 83% in these patients. Yes, it's still. And the complication, how to deal with, is very important. And these are the percent we have to discuss. And these percentage shown is by some studies, but like still in the whole conclusive thing about systematic review, it shows that the neurological insults. And the respiratory depression is one of the commonest. It's not a lot. It's still a lot of patients have this problem, and that depends on the titration of anesthetics. And administration of dexmedetomidine now make it easier to deal with. That will give an access to another drug that we can try and we use, and that make the patient more comfortable even in a wake situation. If the patient start to be incooperative, we still have to encourage him, talk to him, titrate sedation. And I'll tell you something. For every single patient who had an agitation or incooperation in the procedure, I find lowering the sedation level make it more and easier to deal with. Usually we tend to go, and that's a normal response, a normal reflex for us is to increase the sedation and make the patient more asleep. But that will lead you to go further and further for the GA, and that's where you lose the whole advantage and you lose the whole effort we have done. Nausea and vomiting, it's not at the GA, which is a very common side effect and complication in whole neurosurgical procedure. And the whole antiemetic, you can give the prophylactic antiemetic, we don't mind, but still one of the things is the pain that might induce the nausea and vomiting, and you have to ask him clearly about that. Just to mention very fast, to keep it in your mind, there is a lot of challenges out of the patient you have to keep your eyes on. One of them is the temperature of the norm and keep the hemostasis itself. One of them is to keep the whole environment calm, to control more than 8 or 10 person in the single room. And they know what the rule is, but just to keep an eye contact with everyone and to keep talking and to keep explaining the patient. You have to look after the patient's need and to keep interacting with him. And you need to know exactly what test we have to measure. You have the neurophysiologic person who would cover this idea, but you still have to notice that. You might notice some seizures, focal seizures in heart that you have to keep an eye. And the more two things that I have to mention is the bleeding and ICP in the surgery technique itself, which is very difficult to deal in awake craniotomy in fairness. With the bleeding, usually we have to convert, yes, you can deal with a minimal or a moderate loss, blood loss, but up to some level, you have to put a patient to sleep to give him a vasopressor or any other support as well. Measuring ICP, you lost one of the most important tools you have in your hand, which is with the ventilation and keeping the normal CO2. Usually these patients with all sedation will keep hypoventilated. There was studies talking about using of the CPAP or BiPAP to easier getting rid of the CO2. It didn't even evolve to be a general practice in any other centers I'm aware of in fairness. But still we have the mannitol. We prefer to use the mannitol as early as possible if we had suspicions about that. Elevation of the head. Avoid any kink in the neck vein, although it might not be a leading cause, but it might help as well. The other thing going very fast now is the post-operative care for these patients. In fairness, that's one of the advantages of awake craniotomy. Post-operative care for these patients is very easy. ICU admission as planned if this is the patient is planned for any ICU admission, although in most of studies, any other risks like pulmonary infection, urinary tract infection, or DVT it's far way less than the GA, even in the normal surgeries with brain tumors away from the functional areas. It's still very surprising to me, the DVT itself, because he stays still, but like might be the slight movement or contraction of the muscle itself might make a difference. Pain management in these patients is a little bit tricky, because once he gets out from the theater, he will be very comfortable. He had loads of local anesthetic. But then in a 4 or 6 hours, the pain will start shooting. And that depends on the mixture you're using for the local anesthesia. So you have to be aware of this point just to keep the whole thing. You might pass through all of that and the patient won't complain of pain and won't be happy about the surgery itself. Patient satisfaction, in fairness, all of studies that was directed to this point didn't reveal any difference between the GA and the awake craniotomy. Even some studies showed that the patient preferred to do the awake craniotomy and to be aware of that. I was surprised about that as well, but still, that's the case report we're talking about, using the non-invasive positive pressure ventilation. It hasn't been, that was done in 2003, and after that we haven't seen any study to help with that. We usually deal with that, keeping the patient breathing or something like that will help with the brain state of relaxation. Just to conclude my talk, I hopefully it was a little bit enjoyable, and yes, awake craniotomy is a very challenging procedure. It's enjoyable. After you've done it, you will enjoy what you did, but still it's a very challenging. Coordination in every single step, starting from preparation of the patient, preparation with the surgeon, with the neurophysiologist, with the neurologist himself, talking to the patient himself, learning to know him, to know what makes him comfortable, what doesn't make him uncomfortable. Is he claustrophobic? Is he had any problem with that? Different techniques is available now. Dexmedetomidine was introduced like more than 12 years now in the neurosurgery. I have used it, and I'm still gaining the experience about this medication in the neurosurgery. That's why try to keep learning a lot of procedure, a lot of techniques. Try it. Don't be afraid to do that. I usually, in the neurosurgery, we tend to keep the type we master, but still we have this thing to try in the new thing every now and then, just to keep advancement and to keep the innovation in our practice as well. Thank you very much for your attention, and sorry for being long, Walid. You have to unmute yourself, Walid. Sorry for that.
Yeah, sorry for this long time it took us today, but very interesting topics, and really it comes in the exams. So I would really emphasize that if you are attending any MD or any high grade exams, you need to read tonight's both topics carefully, and all the details behind hemodynamic monitoring is one of the most vital topics. Awake craniotomy is one of the most demanding from anesthesia point of view. It needs at least 2 senior anesthetists in the room. It needs extensive communication. I attended very few, so I'm not the expert talking in this field, but when I've seen that in the last few years, it's a high demand procedure from all aspects. Like the time spent on one procedure, maybe 4 or 5 times, or 4 or 5-fold the time spent for any other sleep craniotomy, if Amr agrees with me. So the first question is, what is the correct time of using dexmedetomidine if you are planning to use it in awake?
Oh, that's a good question, and that's a totally different technique. We usually use it once we get an access in the patient. With these patients, we'll put the lines while he's awake, and then we'll start it before pinning. before transferring him to the operating theater, and just will decrease it because the bolus, and usually we have two techniques here, where either we started infusion with 0.7 mics and keep it like that all through, and then modify it because the patient would be awake, he would be sedated, like he would aware about the penning, the local anesthesia itself. The other way is to give a bolus between 1 mic per kg, that over 20 minutes, and then start it with a smaller dose. With the bolus, I'd rather go earlier a little bit, just to be aware and sure that the patient doesn't have any compromise of his airway.
Perfect. So another question here is from Muhammad Hassanin. Is large bore IV cannula mandatory? What do you think?
Yes. Oh, not wide, not a single wide large bore cannula. Like I'm telling you, I started my practice in 2004, and we usually put a central line in these patients. But in the last few years, we stopped doing that with the neurosurgical practice getting better. No, one is not a mandatory. Two is mandatory wide bore cannula for every single patient.
Perfect. I just highlighted the question because it needed to be highlighted. Muhammad Hassanin is asking again, are benzodiazepines accepted option for sedation in those patients?
What benzodiazepines you mean? Like benzodiazepines has been used very early, and they stopped because of the longer duration to recovery, and that will make us to wait. Like we have been using midazolam for a thing with the propofol infusion, and I noticed that it's only my experience that even with propofol, just you will wait longer till the patient is fully awake and you communicable to talk to it, to discuss with, to ask him to move his limb. I like the short acting. There is no ultra short acting than that, the midazolam. So I don't prefer using that. Propofol is the standard. Some people will go for GA. That's very rare now, but like I'm not so sure. I'm not. I haven't practiced that with any other patients.
And the last question is from Ahmed El Gindi. What's your preference after the 23 cases you have done? Sleep, awake, asleep, or awake, awake, awake? What's the preference and why?
I'll tell you, like I have done 20 cases with a sleep, awake, asleep, and just three cases with wake, awake, awake. I think I prefer the dexmedetomidine with awake sedation and using the Bremy. I see it more easier, make it for the patient himself, but still we haven't seen the whole aspect of this medication. Blood pressure control at this point might be a little bit difficult. I'm not so sure. I didn't gain the full experience with the thing, but propofol, using propofol with the sedation, and that's what we're gonna talk about. More changing the word asleep between GA and sedation. It's a thing now that that's a jump for us to do it. Like stop using LMA and just to put the patient to sleep with nasal cannula or nasopharyngeal airway.
Perfect. So I would highlight one point from my own experience, Dr. Amr, if you agree with me. Patient selection is like, we cannot stress it enough. We cannot say enough about patient selection. It is a huge point, because if you did not select your patient properly and he got some stress responses in the awake stage, at this stage it will be very hard for you to push him or to put him asleep, fully asleep again, because airway management will be very challenging and you wouldn't be able to sedate him. And I had seen that in one case, which was not an Irish lady, she was from Pakistan, and it was very hard to communicate with her intraoperatively in the awake stage. So she developed tachyarrhythmias, bradyarrhythmias. It was very hard to challenge. ST segment changes in her ECG intraoperatively. So that gives you major stress as an anesthetist intraoperatively while you're trying to secure the job of the surgeon, talking to the patient in the same timing, treat the arrhythmias in the same time. That's why I'm saying you need at least 2 senior anesthetists plus minus 1 junior anesthetist helps with like preparation of medications or anesthesia nurse or technician, depends on the field. So how you find that, Dr. Amr, in the term of your experience?
No, I totally I totally agree. Even it's not a major stress on the anesthetist. In putting a patient to sleep, you might, all of us notice that if the patient is literally stressed while he's going to be asleep for any surgery, once you give him propofol, you will need more propofol to put him asleep. He will be twitching. I think you have seen that, Walid, in the normal cases. You cannot imagine controlling a patient who is agitated under sedation. That will be impossible. And that's one of the things that's very important to deal with. So if you miss any of these points, as you said, if it's not talking the same language, because he will tell you, I feel warmness in my hand, or I feel burning, and that will scare him because he will start looking. These of all things you have to deal with. You have to tell him that there is a difference between pain, pressure, warmness. All of these are totally different things. And dealing, I literally tell you that dealing with that in Arabic, with an Arabic patient, is far way easier. Even after 4 or 5 years working here dealing with an English patient and but still it's very difficult. At some point, you might feel you have to retain an information. You have something that you are not dealing with easily. So that's the point. You have to meet the patient as a fellow or as a consultant. The single consultant who would put him asleep has to learn the language of the patient, how he pronounce words, how he talks about everything, about his feeling himself. Yes, it's very difficult and long procedure.
Yes, it's a logistics demanding, it's ergonomics demanding, it's human factor demanding procedure. So it's not an easy topic or easy procedure to be performed. But like now you are aware, you got that knowledge part of it. I will end up by saying thanks very much for these 165 attendees that maintained 2 hours 15 minutes with us. My full appreciation and my warm regards to Dr. Amr Salam for being with us tonight, and I know that he did a lot of efforts in this lecture, and like I was pushing hard on him to do it in this Saturday. So my full appreciation, Dr. Amr.
Thank you
and
very
thanks very much. Thanks,
you,
Dr. Ahmad Madi, for being with us tonight. And see you next week. Don't forget, we have 2 very important lectures. One of them is about simulation. I wish you can deliver this message to every single assistant professor and professor in Egypt to attend this lecture. Simulation adds a lot to anesthetics. Simulation in patient safety and in anesthetic practice is a very important, virally going topic. So please be here next Saturday in the same time, 9 p.m. Cairo time. See you. Please stay safe with the new and second wave of COVID pandemic. Thanks a million and have a good night, everyone here. Thanks very much. And I'm ending here.